the whole genesis of the study is the concern that we all have with anti-VEGF therapy in patients with proliferative diabetic retinopathy. So that's a more severe stage of diabetic retinopathy. And those eyes are at high risk of progressing to vision loss. There have been some great studies, randomized clinical trials. There was the DRCR network Protocol S, which clearly showed that ranibizumab monotherapy was equivalent to PRP, probably even better because there was less issues with like visual field loss that you see in PRP, as well as incidence of diabetic macular edema, which you see with PRP. And then there was a United Kingdom Clarity trial, which showed a superiority of an anti-VEGF for the first time, where they found that aflibercept was better than PRP in terms of visual acuity outcomes. So there's definitely a big push to going towards anti-VEGF monotherapy for our patients, but we worry about what happens if they don't come back. We know from the early treatment of diabetic retinopathy study from years ago that you do PRP and those eyes can do very well. So like 84% of patients that got PRP end up with 20/40 vision still at a median of 16.5 years after the PRP. So they held up very long. We have no idea what the long-term durability of anti-VEGF is going to be, especially if patients don't continue to get the injections. So the genesis of our study was to look at what happens to those eyes that got anti-VEGF versus PRP and then were lost to follow-up and then came back. How did they do? So we basically found that there was quite a big disparity between the two groups, which is sort of what we had anticipated as well. So in terms of visual acuity outcomes, right before the patients were lost to follow-up, the mean visual acuity was about 20/50 in both the anti-VEGF and the PRP-only groups. However, when they returned from being lost to follow-up, and the mean duration that they were lost to follow-up was actually over a year, the anti-VEGF group had lost vision to about 2200, whereas the PRP group had also lost vision to about 2080. However, they were followed for an additional amount of time after they returned, got some additional treatments, and the PRP group improved back to their baseline, about 2050, whereas the anti-VEGF group remained around 2150. So definitely worse visual acuity outcomes. The other issue was with anatomical outcomes. We saw a higher rate of neovascularization of the iris developing in patients that only had anti-VEGF therapy on board. At the final visit, there were 4 of the 30 eyes that had NVI, and of those, 2 of those eyes developed neovascular glaucoma, whereas there were no cases of that in the PRP group. In addition, traction retinal detachment. So we saw 10 eyes out of 30. So a third of the patients developed TRDs by the final visit in the anti-VEGF group, whereas only 1 out of 47 eyes in the PRP group got a traction retinal detachment. And of those eyes, 6 patients in the anti-VEGF group ended up needing vitrectomy to repair the TRD. So it was that severe. And that's 20% of those eyes versus none in the PRP group which required vitrectomy for TRD. In terms of clinical management, it has changed the way I manage these patients to some extent. I'm definitely more wary about going with anti-VEGF monotherapy. And even if I'm not planning to do anti-VEGF monotherapy, a lot of us will start treating these eyes with anti-VEGF, thinking in the back of our head, okay, once we stabilize their vitreous hemorrhage or their diabetic macular edema, then we're going to start the PRP. But we have to keep in mind that there are some patients that even got 1 injection or 2 injections and never came back. So not only do we need to be cognizant of that, we also need to explain that to the patients very carefully of the need to follow up. I do, as a result, have a lower threshold for still doing some PRP, probably not as heavy as I used to in the era before we had anti-VEGF, but some PRP to at least hopefully give them some durable effect if they don't come back.